If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome. I'm Fernando, a GP in the UK. Today, we're looking at a nice guideline on vitamin B12 deficiency in adults, published as recently as March 2024, focusing on what is relevant in primary care only. Make sure to stay for the entire episode, because at the end, I will tell you how to access an interactive flowchart that I have created and that summarizes the guidance. Right, so let's jump into it. Let's start by looking at common symptoms and signs of vitamin B12 deficiency, which are anemia or macrocytosis on a full blood count, but we should not rule out the diagnosis of vitamin B12 deficiency based solely on the absence of either anemia or macrocytosis. Difficulty concentrating or short-term memory loss, also sometimes described as brain fog, bursitis and mouth ulcers, unexplained fatigue, eyesight problems related to optic nerve dysfunction, for example, blurred vision, a visual field loss or scotoma, and optic atrophy signs on fundoscopy. Neurological or mobility problems, including balance issues and falls due to impaired proprioception or sensory ataxia, impaired gait, and paresthesia. And finally, it can also be associated with mental health problems, including symptoms of depression, anxiety, or psychosis. There are also common risk factors for vitamin B12 deficiency. Before looking at them, let's briefly look at the physiology of vitamin B12 in the human body. In food, vitamin B12 is generally bound to protein. So in the stomach, gastric enzymes such as pepsin separate the vitamin B12 from the protein. Then the freed vitamin B12 combines with a protein produced by parietal cells in the stomach called intrinsic factor. The vitamin B12 intrinsic factor complex is taken to the cells in the terminal ileum, where the vitamin B12 is absorbed. So in summary, for vitamin B12 to be absorbed effectively, we need a sufficient dietary intake and normal physiological processes in the stomach and terminal ileum. So, with that in mind, the common risk factors for vitamin B12 deficiency are diet low in vitamin B12, for example, people who follow a vegan diet or low in animal source food, people who do not consume items fortified with vitamin B12, people who have an allergy to some foods such as eggs, milk or fish, and people who have difficulties following a well-balanced diet, for example, in dementia, frailty and mental illness, in low-income situations, and in eating disorders. Other risk factors include conditions such as atrophic gastritis, celiac disease, or another autoimmune condition, and previous gastrointestinal surgery like bariatric surgery and gastrectomy or terminal ileal resection. Some medicines like colchicine, H2 receptor antagonist and PPIs, metformin, and some antiepileptics like phenobarbital, pregabalin, primidone, and topiramate. A family history of vitamin B12 deficiency or an autoimmune condition, and finally, recreational nitrous oxide. We should use our clinical judgment as to when to check for vitamin B12 levels, paying attention as to whether patients have symptoms, signs, and risk factors. In order to diagnose vitamin B12 deficiency, we will use either total B12 or serum cobalamin, or active B12 or serum holotranscobalamin, unless the test needs to be done during pregnancy, when we should always use active B12 or serum holotranscobalamin, or if recreational nitrous oxide is the suspected cause, when we will use plasma homocysteine or serum methylmalonic acid or MMA. We should not delay vitamin B12 replacement while waiting for the test results in suspected megaloblastic anemia, neurological symptoms, or suspected vitamin B12 secondary to medication. We will use caution when interpreting test results if they're already using an over-the-counter preparation containing vitamin B12, because they may mask a deficiency but may not fully treat it, or if they're taking a combined oral contraceptive pill, because this can lower total B12 concentrations without causing a true deficiency. We also need to be aware that people of black ethnicity may have a higher reference range for serum vitamin B12 concentrations. The NICE guidelines give vitamin B12 thresholds to decide whether the vitamin B12 deficiency is unlikely, confirmed, or whether the value is indeterminate. But it also recommends using local validated thresholds if they exist. So in the absence of local guidance, we will follow these thresholds. If total B12 is less than 180 nanograms per liter, or active B12 less than 25 picomoles per liter, then the vitamin B12 deficiency is confirmed. If total B12 is more than 350 nanograms per liter, or active B12 is more than 70 picomoles per liter, then the vitamin B12 deficiency is unlikely, and we will investigate other causes of their symptoms, and if they are still experiencing symptoms 3 to 6 months later, we will repeat the vitamin B12 test. And finally, if total B12 is between 180 and 350 nanograms per liter, or active B12 is between 25 and 70 picomoles per liter, then the vitamin B12 levels are considered to be indeterminate, meaning that vitamin B12 deficiency is possible but not confirmed. In these cases, we will measure serum MMA concentrations if there are symptoms or signs of deficiency. While waiting for the results, we will start vitamin B12 replacement if they could deteriorate rapidly, for example, neurological or hematological conditions such as ataxia or anemia. If they have a suspected irreversible cause of vitamin B12 deficiency, for example, autoimmune gastritis, a gastrectomy, terminal ileal resection, or some types of bariatric surgery, or if they're pregnant or breastfeeding. If the vitamin B12 deficiency is confirmed, we will investigate further and we will check for anti-intrinsic factor antibodies. If autoimmune gastritis is suspected, bearing in mind that a negative result does not rule out the presence of autoimmune gastritis. If autoimmune gastritis is still suspected, despite a negative anti-intrinsic factor antibody test, we will consider further investigations such as an anti-gastric parietal cell antibody test, a test to measure gastrin levels, a co-absorb test to measure whether vitamin B12 can be absorbed, and gastroscopy with gastric body biopsy. And if the cause of the vitamin B12 deficiency is still unknown, we will test for celiac disease. In terms of the management of the vitamin B12 deficiency, the management will vary depending on the cause. In malabsorption due to autoimmune gastritis, a total gastrectomy, or a complete terminal ileal resection, we will offer lifelong intramuscular vitamin B12 replacement. In malabsorption for other reasons like celiac disease or bariatric surgery, we will consider intramuscular instead of oral vitamin B12 replacement. But if we offer an oral preparation, we will prescribe at least 1 milligram a day. In medicine or nitrous oxide-induced vitamin B12 deficiency, we will give either intramuscular or oral vitamin B12 replacement based on our clinical judgment, and we will advise to stop nitrous oxide and consider stopping the medication causing the deficiency if appropriate. If the vitamin B12 deficiency is due to diet, we will give dietary advice, we will consider oral vitamin B12 replacement, and during pregnancy or breastfeeding, we will give at least 1 milligram daily. And we will consider intramuscular vitamin B12 injections if the condition deteriorates rapidly or there are concerns about adherence to oral treatment. We will also explain that some over-the-counter supplements may not contain enough vitamin B12 or the right type to be effective, and advise them to pick an oral supplement that contains cyanocobalamin, methylcobalamin, or adenosylcobalamin. In unknown causes of vitamin B12 deficiency, we will consider oral instead of intramuscular vitamin B12 replacement and review the response to treatment. Initial follow-up appointments after starting vitamin B12 replacement should be at 3 months or earlier, depending on the severity of the symptoms, or at 1 month if they're pregnant or breastfeeding. In oral supplementation, we will ask about symptoms, and if they have not sufficiently improved, they have got worse, or there are new ones, we will increase the oral dose to the maximum licensed dose. Or if they're already taking the maximum, we will switch to intramuscular injections and consider further testing with serum MMA or plasma homocysteine. If the symptoms have resolved, we will continue with oral vitamin B12 replacement if the cause has not been addressed. For example, the person is still taking medicine that could affect vitamin B12 absorption, or the cause of the deficiency is unknown. But we will consider stopping treatment if the symptoms have resolved and the cause has been addressed. For example, the person has increased the dietary intake, although we will advise to come back if symptoms develop. For people receiving intramuscular replacement, we will not repeat the initial diagnostic test. If the symptoms have not improved enough, we will increase the frequency of the injections if needed, in line with a summary of product characteristics, and think about alternative diagnosis and agree a date for reassessment of the person's symptoms. If a person has or is suspected of having an irreversible cause of vitamin B12 deficiency, we will continue with lifelong intramuscular injections even if the symptoms have resolved, and we will advise them to come back if symptoms recur. If the person's symptoms have resolved and they have either a reversible cause that has not been addressed, for example, continuing medication, or the cause is unknown, we will continue with intramuscular injections and we will continue to follow up. But if the cause has been resolved and the symptoms have disappeared, we will think about stopping or reducing the frequency of the injections and advise them to come back if symptoms recur. As we have seen, the guideline covers deficiency caused by autoimmune gastritis. But let's pause for a minute. Is autoimmune gastritis the same as pernicious anemia? Well, NICE does not use the term pernicious anemia in this guideline, so let's see why. Autoimmune gastritis can destroy the parietal cells in the stomach, which can prevent the absorption of vitamin B12 and also impair iron absorption. Although pernicious anemia can be a consequence of chronic severe vitamin B12 deficiency caused by autoimmune gastritis, pernicious anemia in its true sense, that is, life-threatening anemia, is now extremely rare, and for this reason this term has not been used in the recommendations. Also, although autoimmune gastritis is associated with the presence of autoantibodies against gastric parietal cells and intrinsic factor, which can be detected in blood tests, we should also bear in mind that they're not always present, and even when they are present, this is not always indicative of autoimmune gastritis. We also need to take into account that people who have autoimmune gastritis are at higher risk of developing gastric neuroendocrine tumors and may also be at higher risk of developing gastric adenocarcinoma. So we will refer them promptly for gastrointestinal endoscopy if they develop new or worsening upper gastrointestinal symptoms, for example, dyspepsia, nausea and vomiting. To end the video, NICE has created a 2-page visual summary on ongoing care and follow-up options for oral and intramuscular vitamin B12 replacement. Let's have a look at it. So, for people on oral vitamin B12 replacement, at follow-up, if the symptoms are not sufficiently improved, we will either increase the oral dose to the maximum licensed dose, or if they are on this already, we will switch to intramuscular administration, taking into account the patient's preferences. If there are new or worsening symptoms, we will see if the diagnosis was made using methylmalonic acid or MMA or plasma homocysteine. If the answer is no, we will think about alternative diagnosis and consider testing serum MMA, or if not available, plasma homocysteine, continuing treatment until the results are received. When the results are received, if the deficiency is still present, we will either increase the oral dose to the maximum licensed dose, or if they are already on this, we will switch to intramuscular administration, taking into account the patient's preferences. However, if the results do not show a deficiency, we will explore alternative diagnosis to explain the symptoms. If the answer to the questions about MMA or plasma homocysteine testing is yes, then we will consider alternative diagnosis, and taking into account the patient's preference, we will either increase the oral dose of vitamin B12 to the maximum, or if the patient is already on the maximum oral dose, we will switch to intramuscular injections. Finally, if the symptoms have improved or resolved, if the cause has not been addressed or is unknown, we will continue with the oral replacement and continue follow-up. On the other hand, if the cause has been addressed, we will consider stopping treatment, advising the patient to seek medical advice if the symptoms get worse, reappear, or new ones emerge. Now let's have a look at the summary for patients on intramuscular vitamin B12 replacement. So, at follow-up, if there are new symptoms, they are worsening or have not sufficiently improved, we will increase the frequency of injections. We will think about alternative diagnosis, and we will continue reviewing the patient. Conversely, if the symptoms have improved or resolved, if the cause is irreversible, we will continue with lifelong injections, advising the patient to seek medical advice if the symptoms reappear, get worse, or new ones appear. However, if the cause is reversible, but it has not been addressed or is unknown, we will continue with injections and regular reviews. And finally, if the cause has been resolved, we will think about stopping or reducing the frequency of the injections, advising the patient to seek medical advice if the symptoms get worse, reappear, or new ones emerge. I have created an interactive flowchart that incorporates these visual summaries as well as other nice guidance, and also advice given by the British Society of Hematology. You can access it in the episode description. I hope that you will find it useful. We have come to the end of this episode. Remember, this is not medical advice, and it is only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.